Okay, our next type of stim, and we're going to do kind of two of them together here, is what we call neuromuscular electrical stimulation. And one of the main uses of this is for what we call muscle re-education or potentially muscle strengthening. We can also use it for edema reduction as well. So what we're trying to do is create a muscle contraction through the nerve stimulation. And so to do this, one of the most important things is you got to make sure you have a machine that can do what we call a duty cycle, okay, where we can have that on-off time that we can set. A lot of different waveforms can be used, but mostly when we're talking about NMES, we're talking about a biphasic waveform, and we'll talk about Russian next, which is another one. None have really been proven better. Again, if your machine has a variable muscle stimulation waveform or a VMS, that's another one you can use. So what happens when we're electrically stimulating, again, we're targeting now in those cases the A alpha, those motor nerves. We're not actually targeting the muscle fibers themselves. That would take such a long duration and such a high intensity that it would be really painful. The only time that really gets done is when the muscle itself is, the nerves are denervated, so that, because then the person doesn't really feel that pain, and we're really just trying to target. So again, the Bell's palsy and the polio and some of those conditions are where you maybe actually target the muscle fibers themselves. We're going to try to target the motor neuron going to those muscle fibers, so those A alphas. And when we do that, so the little chart down in the corner shows you that there's kind of a difference in how we electrically induce a muscle contraction versus how your body naturally does it. So when you naturally do this, you have your fast twitch and your slow twitch. So usually your body kicks in the slow twitch, the smaller diameters one first, because they're going to be the ones that could tolerate a longer time, and your body isn't sure what the resistance that it has to overcome is. And so they kick in first, and then if the resistance is sensed as great enough, then your fast ones kick in. And so those slow diameter ones usually have that slower onset of fatigue. The contraction and recruitment are kind of asynchronous in order to decrease fatigue. So it will kind of move from different motor units to try to keep them all from fatiguing out at the same time. And your Golgi tendy organ can protect the muscle. So this is the idea of our reflexes, right? So when that tendon feels too much stretch on it, if things are happening too quickly, it's going to tell the muscle to contract so that it protects the area, and it will protect you from too much muscle force production. Now, when we electrically induce that, we lose the Golgi tendon. The Golgi tendon can't override the developing tension. So it's our job to make sure we don't have anything on too high. There's also a flip, a reversal of the recruitment order. Large diameter fast twitches are recruited first because of how they are then more likely to be stimulated by the electrical current because of their diameter. If you think back to that conversation earlier in our videos. So the contraction and recruitment are synchronous, meaning they're happening kind of at the same time based on the number of pulses per second that we set. And so we have a much faster onset of fatigue. So again, it becomes our job to use this in the appropriate manner so that we're not fatiguing out the individual and that we can actually get the results that we want. And so the effects that we want is usually to produce that muscle contraction, and we're usually trying to give them feedback in order so that we can retrain them to produce a voluntary muscle contraction, and that's what we call muscle re-ed. We can also use it to delay disuse atrophy. So if they've been casted or can't do a lot of activity, anything beyond isometric, which means, again, not changing the joint angle, right? So by sitting on the table, we could use the stim to keep the muscle firing and keep the muscle strong while the person recovers until the person can do more active muscle contraction. Can also increase peripheral blood flow to the extremity, and we can also have edema reduction because of the venous and lymphatic return that can happen, but we would set our rates much lower for that. We can potentially increase range of motion. That has more to do with increasing the strength in the muscles around the area so that they can produce the range of motion. We can decrease muscle inhibition. So again, when we're injured, if you remember back to that loss of central control and the spinal adaptation theory, Stain's spinal adaptation theory, muscle will, because of the injury and the swelling in a joint, the muscles will become inhibited and we can't control them the same way we normally could. And so by doing the electrical stimulation, we can start to override that. And it can override muscle spasms, and we can potentially get some pain relief with that. However, this is a pretty intense treatment, so there's better ways we could probably target that with our level 3 pain control, or even our level 1 pain control. If that's your only goal is to decrease those muscle spasms, there's other ways we can do that, probably more efficiently for our patient. So advantages, we can use it on an immobilized body part. We can supplement voluntary muscle contraction. So again, they can get the sensation and the stimulation from the electricity that then helps them produce the muscle contraction and them work on producing their muscle contraction. Disadvantages, again, just like all of our stim, can be kind of a cure-all mentality. Well, I don't have to train or do my exercises because the e-stim is producing my muscle contraction. And that's just not true, because it's only an isometric contraction, and we know the person does not have to be strong isometrically. They have to be strong isotonically in order to be able to produce and return to normal activity. So it should always be used as an adjunct therapy and not the sole purpose of muscle strengthening. Our indications, residual or chronic muscle spasms, again, we potentially have better ways to treat that. Abnormal neuromuscular function, if they've been casted or immobilized, disuse, atrophy, pain, but it's usually pain because of the disuse or the lack of neuromuscular function. This is not what I would use if they're just in pain for any other reason. Contraindications are all of our same. We add also, if we wouldn't want the muscle contraction happening. So again, our acute inflammatory conditions. If that's going to be more painful, we're not going to want to create a muscle contraction, so we wouldn't want to use NMES. Pre-application steps, all the same. So again, preparing the patient, asking all the right questions, making sure you have your goals set. Now when we're explaining the procedure, so again, we'll feel pins and needles, but it's going to be a little more intense. We're trying to get to a muscle contraction. And what we're trying to mimic is a muscle contraction. Different books say different things. Some say you have to get at least to 30% of the maximum voluntary contraction, or MVC. Some put it that you want to mimic one somewhere between 50 to 80% of the MVC. Basically, if you're above 30, you're doing okay. And what that means is look at the uninjured body part. So we do this a lot on quads post ACL surgery. The quad gets really inhibited because of all the swelling in the knee, plus being immobilized. So they lose a lot of their quad strength and their ability to contract their quad. They think they're contracting, they look at it, and it's not doing anything. And so we're trying to retrain that. So if their left leg is injured, we'd want on the right leg to have them fully contract their quad isometrically in the same position that the other leg is going to be in. Okay, so we'd have them actively contract, and then we would, as we're turning up the machine, want to mimic somewhere between 30, 50, 80% of that. So usually you start lower, and then as the person can tolerate, you increase that percentage. And so you want to mimic what they can do on the other side at a certain percentage. You never want to create the full 100% MVC. That's just going to fatigue too quickly, and we don't want to risk, again, remember the Golgi tendon organ can't protect it, so we don't want to risk that contraction coming on too fast that the individual ends up actually injuring themselves further. So that's kind of the goal. We're going to end up, it shouldn't be painful, but it doesn't feel great. I will tell you that. The NMES, using more of our biphasic waveform, I think feels a little bit better than the Russian that we're going to talk about next. But it's also a little bit harder to get to the level that you want to get to. You have to kind of increase your intensity and play around with your pulse width and frequency a little bit more than you do with the Russian. The Russian tends to be easier to get your muscle contraction, but it also tends to feel a little bit more uncomfortable. So for our muscle re-ed, we're going to have that biphasic waveform. Our frequency is somewhere between 30 and 70 pulses per second. So our pulse rate or our frequency. So usually a good place to start is about 50, and then you can play around. What we want to get is tetany. We want to get a solid muscle contraction. okay? Not the twitching that we got with our level 3 pain relief. So we again want to mimic 50 to 80% or at least above 30% of the MVC. Your pulse width should be about 30 microseconds at least. So again, the longer we can get our pulse width, the better. Pulse duration, or our duty cycle, I should say, is the fact that we want to set that. So we want to have some off time so that they don't fatigue out. And we want it to mimic a natural muscle contraction. So you can have different ratios or percentages. Your book talks about wanting to be at 25% when you're first starting, and then you can up it. A lot of sources talk about 10 seconds on, 50 seconds off, or that 1 to 5 ratio. You can kind of play with your patient of how much off time they need and how much time on they need. But anything more than kind of a 10-second contraction is a lot. And you also want to potentially ramp. And so remember that ramping is this idea that we can kind of slow down how quickly we get to our peak. So it has a little bit to do with our rise time. You want, if you just shot the waveform going, if we just let it turn on naturally, it's going to come on much faster than a natural muscle contraction. So usually when you have a muscle contraction, it kind of eases on and then eases off. And so you'd want to maybe take your ramping up a bit so that it comes on a little more gradually, especially when you have that off time. You don't want the person to all of a sudden be kind of shocked as the machine kicks in. You want it to kind of kick in more gradually. And then our treatment time is really the reps that you want done. So if you want 8 to 10 reps done and you're doing 10 seconds on, 50 seconds off, then that's an 8 to 10 minute treatment. You can go up to 30 minutes, but again, you got to watch that fatigue as you do that. Our electrode placement is usually bipolar, where we usually put one pad more over the proximal part, the proximal end of the muscle, and another pad more towards the distal. You can also try to target those motor points for that. You can do a monopolar setup, but you would really need to be over specifically a motor point for that muscle in order to do that monopolar setup. And you'd only want to do that for really smaller muscle groups or muscles that you need to target just that muscle. So the frequency of the application, we're looking at about 2 times a day with at least 3 to 4 hours in between. Because what you're going to do, so you have that ratio time, on time and off time. So the machine's going to kick on and the contraction's going to hit. Then during the off time, you want them, if you're doing true muscle re-education, you want them to try to mimic what the machine did. So they're going to try to contract their muscle during that off time. And again, they're going to do as many reps as they can get in that 50 seconds or 30 seconds or whatever you've set your machine to be in the off time. And then the machine's going to kick back on with the muscle contraction with the electrical stim. And so you use that off time for them to be able to start trying to recreate those neural pathways to be able to control the muscle contraction themselves. That's the goal. If you're doing more of an edema reduction, okay, you can do if you have just a normal setup, you can do almost kind of in our like level 3 where we have kind of the 2 to 10 pulses per second where we get more of the twitch. So think of like a bad ankle sprain. We could put the pads along the calf so that the ankle kind of twitches so that we get some of that muscle contraction to flow the lymph and the venous return back up to the heart. So usually we do this in conjunction with elevation and some compression. If you have what's known as an alternating setting, if you can set up an alternating setting and you have 2 leads, 2 currents, 2 channels, you can set one on the calf and you can set one on the hamstring. And then the alternating will vary them just enough that the calf contracts and then it releases, and then the hamstring contracts and releases, and then the calf and then the hamstring. And so you'd use your same settings to get the tetany, so the 30 to 70 pulses per second and the 30 or 300 microsecond, but you would be alternating the calf and the hamstring in order to pump even more effectively, potentially. But you have to be able to set up that alternating modulation there. And then post-application steps are all our same, okay, that we've been talking about. So ask them their pain scale and their patient-oriented outcome, check the area, remove the pads, Make sure you set up your next appointment, tell them their restrictions, give them their instructions, document everything, and then all of our maintenance. So we're going to counter NMES to Russian, okay? So NMES uses that biphasic waveform. Russian actually uses a medium frequency. So we're actually leaving behind our low frequency. So in the notes, in the packet in the notes, you can actually see kind of the family tree of E-stem I've put in there. We're leaving kind of behind the low frequency and moving into the middle or medium frequency. Now remember, medium frequencies we talked about have greater ability to overcome resistance in the body. And so again, it becomes easier for this stimulation to get into the body and potentially create our muscle contraction. It was developed in 1976 by Dr. Kotz, who is a Russian in the Soviet Union. And it was originally created to aid training the Soviet athletes for the Olympics in order to gain strength. It was later found that yes, even though they made strength gains, they only made strength gains isometrically because you're not training isotonically. And so it was no substitution for regular strength training. So that medium frequency means it's capable up to about 25,000 hertz. It's a sinusoidal wave, so a sine wave, that gets interrupted in bursts. And those bursts are what create the muscle contraction for us. So it's a much higher frequency than our NMES that we just talked about. And in order for it to be tolerable, those waves have to get transformed into the bursts. So we pack a higher intensity into those little bursts, kind of like our burst mode that we talked about with TENS, but on a much higher scale. It's just with the, like with the NMES and with now with the Russian, more is not necessarily better because it will elicit pain. All we want to do is get to the muscle contraction, to the level of the muscle contraction that we want. And we don't want to go more than that and cause pain for the individual. So our effects are very similar to our NMES. We want to produce that muscle contraction, delay disuse atrophy. It will increase peripheral blood flow, potentially edema reduction, though we're much more likely to use the NMES for the edema reduction than Russian. Increase the range of motion, decrease muscle inhibition, pain relief potentially by decreasing the muscle spasms, but like I said, that's not the way we would really target muscle spasms if that's the only issue that we're dealing with. Advantages, same advantages as we had with NMES. Again, the advantage of Russian over the NMES is that it might be easier for us as the clinician to be able to target those motor neurons that we're trying to target, and it will decrease the resistance. But you just got to kind of play along and compare. All of our contraindications are all the same, okay, that we had for NMES. Our steps are all the same, our pre-application steps. And then comes to our settings and explaining the procedure. So you'll explain the procedure the same way you did NMES. It should be moderate pins and needles. We need to get to that muscle contraction. And again, you're trying to mimic that 80 or 50 to 80%, at least greater than 30% of the MVC, the maximum voluntary contraction of the other non-injured side. Again, assure them, make sure they're comfortable. Make sure that the area is prepped properly, that the electrodes have good contact. And so our settings, our frequency is the 30 to 70 pulses per second, just like it was for NMES. Now we don't set a pulse duration. Our pulse duration is preset for us because of the high frequency. Very similar to the high volt, when we're moving into these higher frequency modulations, the pulse rate gets preset, or the pulse duration gets preset for us. You'd want to set your duty cycle, same as we did with NMES. You got to kind of work with your patient and decide what's best for that. Same treatment time. Again, setting up ramping if that's possible. We'd want that to come on more naturally. The electrode placement is the same for the NMES. So ideally bipolar, where you have one proximal, one distal. If you have smaller, you might use a monopolar setup. Again, the Russian stim in theory should overcome resistance easier, and so you have a little more forgiveness if you're not directly over a motor point or something like that. Frequency of the treatment 2 times a day, 3 to 4 hours in between, just like our NMES. And then all of our post application is the same, as well as our documentation and maintenance.